Dear colleagues, thank you very much for inviting me to this 9th workshop on endometriosis and infertility of the MSERM. I'm delighted to be with you online, and my task today is to talk about surgery for colorectal and sacral root endometriosis and intermediate and long-term outcomes of these interventions. So endometriosis has been an issue of clinical practice for over 200 years, and it has been Professor Rokitansky in 1860 who ever first described this disease in Vienna. And since then, a lot of time has passed, and surgical therapy has evolved a lot. So if we talk about surgical interventions for extensive colorectal and sacral root endometriosis, we have to question ourselves, what is the indication for radical surgery? What are the intermediate outcomes regarding complications, pain reduction, fertility? And what are the long-term outcomes? Meaning, what are the outcomes following 6, 7, 8 years post-operatively? And we do very limited evidence on that. Well, the primary indication to perform these interventions, to perform multidisciplinary interventions, to perform surgery for non-malignant disease involving extensive urological surgery or colorectal surgery, is organ dysfunction, meaning hydronephrosis, organ impairment, colorectal stenosis, which is quite rare. The second indication would be quality of life reducing pain not responding to medical therapies. And the third would be, under certain circumstances, infertility, especially in patients where ART does not lead to success. So if we look at probably the most extensive form of deep endometriosis, which is endometriosis affecting the sacral roots, we do find patients with very intense and special pain symptoms. And I'd like to briefly highlight that pain in patients with sacral root endometriosis does cause sacral radiculopathy, meaning that there is a distinct somatostatic pain affecting the dermatome of the sacral root affected by the disease. And this is the utmost priority to actually correctly diagnose these patients. So how do these surgeries look like, and how does it actually take place? And as you can see in this patient, the disease is not obvious. Some colleagues would classify this as ARSRM stage 1 endometriosis, again highlighting the inadequacy of this classification. As you can see, this is a patient with extensive rectal disease, also involving the left sacral root S2, S3, with sacral radiculopathy, radiating pain in her bottom and lower extremity. And again, also involving her lower rectum and vagina. And this patient did neither respond to medical treatment and also had a relevant fertility issue. And these patients are eligible for surgical interventions. So as you can see, resection does involve dissection of the sacral roots, does necessitate extensive anatomical knowledge and surgical competence when performing these interventions involving segmental resection, partial vaginal resection, sacral root dissection, etc., etc. So these surgeries are very complicated pelvic surgical interventions and do necessitate adequate planning. And the question on what technique to perform is not the main task today, but I'd briefly highlight that multifocal disease does often necessitate segmental resective management. So what are the intermediate complications and problems of these surgeries? And as you can see, the overall main clavin-DINO3 complication rate ranges between 2 to 9%. And we do face, of course, dependent on the extent of surgery, dependent on the height of the anastomosis, dependent on concomitant vaginal resection, also dependent on surgical experience, fistula rate of anastomotic leakage of about 2%. It may be less in shaving techniques if they are appropriate, but they are nearly equal in discrete resections and segmental resection techniques. So these complications do happen. They are not that common, but they do have a relevant morbidity. So if we look at our own series, as you can see, we faced an anastomotic leakage rate of about 2% and rectovaginal fistula rate of about 1% in a series of 140 patients undergoing either discrete and segmental resection. And we have been unable to define a difference between either technique. The reduction of pain in these patients is significant. So as you can see, and this is in line with a big body of evidence stating that the very majority of these patients will have a relevant reduction of pain. They will not be completely pain-free, but as you can see, pain scores drop down to NAS 2, 3 from 8 to 10. And this reduction is relevant because this reduction means that these patients will be able to experience a change in their quality of life and will experience amelioration of symptoms. So it is quite clear that appropriate and well-performed surgical interventions are effective regarding pain reduction in the intermediate outcome point of view. Regarding sacroradicalopathy and sacroroot endometriosis, there's very limited evidence because surgery for these patients is not very well investigated. But as far as from what we know so far, it appears that these surgical interventions, although they are very complex and do have relevant morbidities, do also lead to a really relevant reduction in pain symptoms, although these ameliorations will appear after a couple of months, and you may have to face morbidity regarding hypogastric or autonomous nerval dysfunction, with a relevant number of patients being confronted with transient voiding dysfunction, etc., etc. But under the line, from what we know so far in my own experience of about 20 cases, which we have performed with my colleague Attila Bocca in Budapest, shows that this reduction is relevant and existent and significant. It will be more complicated to tell you about the effect of this intervention on fertility. And the main reason is that there are multiple factors influencing the fertility outcomes. And as we all know, it's not only about removing endometriosis, it's also about ovarian reserve, age, partner's age, etc., etc. And as you can see, these factors do greatly vary, leading finally to a big range of outcomes or result. And as you can see, spontaneous conception rates in the published literature so far range between 20 and 61%, with overall birth rates or live birth rates, again, providing or showing a big range depending on probably number of surgical techniques, age, etc., etc. So there does appear to be a relevant effect, but there is no consistent definable number or percentage of success. And this has led to a rather clear statement in the just recently published ASHRAE guideline, where we also took part. And It basically suggests that in a setting where you have a symptomatic patient aiming to conceive spontaneously, although no compelling evidence exists that laparoscopy for deep endometriosis improves fertility, it may represent a treatment option in patients wishing to conceive and symptoms. And the lack of evidence is possibly reflected by the lack of very well-designed randomized controlled trials, which are difficult to design, obviously.